Today we're going to discuss on Pheochromocytoma, the clinical presentation, anesthetic management, and perioperative care in Pheochromocytoma. And today, the whole topic is dealt by the PG Institute at Rohtak, Haryana. And as Dr. Murali was telling, it is a really woman's show. We are lucky. We were able to have women's show at least 3-4 times in the past. It started with a trauma anesthesia from Chandigarh, and now it is carrying on. It is a very good legacy. We will keep it up. And today's the floor managers are Dr. Savida Saini and Sushila Taksak. Well, both are known to you all very well. Savida is a senior professor, and she was the head of the department till now. And she has a lot of credits to her name and is a well-recognized and accepted anesthesiologist as well as academician. And Sushila, well, I don't know you tell, she's one of the young active face in ICA, and she's doing a lot to promote ICA. So these two patients will be controlling the show today, and the faculty members are Preeti, Tina, and Priyanka, and they are all from the Rohtak Institute of Medicine. And I request Dr. Saini and Taksak to go ahead.
Hello, good evening. Am I audible?
Good evening, ma'am.
Good evening, ma'am.
So, good evening, Dr. Preeti. Good evening, Dr. Tina and Dr. Priyanka. So, I will like to have slide of Dr. Preeti's CV, which I can say, but definitely if it is not there, even then I can speak for her. As introduced by Dr. Radhakrishnan, the topic of today is Pheochromocytoma, which is very, very important for all of us, because this is, we all know it is a real challenging task to manage Pheochromocytoma perioperatively. One really has to have a meticulous evaluation of the preoperatively of the patient, optimization, optimization before taking a patient for the surgery, meticulous intraoperative monitoring all through the surgical period, and extended postoperative care. So Dr. Preeti, who is associate professor, I think Preeti's that's fine. She is associate professor at Postgraduate Institute of Medical PGIMS, Rohtak, and she is a very, very lively personality. She has been taking active participation for organizing various conferences of the department as well as outside other departments of the institute as well. So that is a real creditable part. She has got that thing. She has been faculty to various national and zonal conferences, and she is at present joint secretary of HSMTA, that is Haryana Medical Teachers Association also. She would be presenting, she has her interest, we all know, difficult airway, USG guided block, critical care. I mean, all those things which you can think of these days are required. She has interest in those things. So Dr. Preeti would be enlightening us on the overview of the Pheochromocytoma and its clinical presentation. We all know it has an important triad of clinical presentation. She'll be deliberating in detail about what Pheochromocytoma is, the pathophysiology, and its clinical presentation. Dr. Preeti, please go ahead.
Thank you so much, ma'am. And ma'am, one more thing, you said I'll be enlightening. No, I am a student in front of you all stalwarts who are sitting here. So I'll just try to speak whatever latest I could gather from all the sources. So good evening, everyone. My topic today is overview and clinical presentation of Pheochromocytoma. I am associate professor currently at Pandit B.D. Sharma College, Rohtak. Speaking of Pheochromocytoma, it's a tumor of adrenal gland. So first, anatomy is important here. basically we have two adrenals, which are also called as suprarenal glands. Now they are small in size, measuring roughly 5x3x1 and weigh 4 to 5 grams. The right one is pyramidal in shape, and the left one is almost semicircular. So here the associations are important in the body. It is the right one is in close proximity to the inferior vena cava, to the liver and the right diaphragm, and the left adrenal gland is closely associated with the aorta, spleen, and tail of the pancreas. The structure is divided into cortex and medulla, where cortex forms the major part and medulla is the smaller part. Now, having a look at the picture here in relation to the body. So they are situated on top of the kidneys. And this is a picture where it shows roughly to give an idea how they are placed inside the human body when we look at it. Now, embryology is very important because that is how we know the distribution of the adrenal tissue that can be there in different parts of the body. So the adrenal cortex, the outside part, it comes from the mesodermal cells, and adrenal medulla, the central or the middle part, it comes from the neuroectodermal cells. But what happens during the development, some neural crest cells also migrate to the para-aortic and paravertebral areas. So this most of this extra adrenal neural tissue, it regresses, but it may persist at certain sites. So now this is a schematic diagrammatic representation to give an idea of the development, where the important part is that by around 4 years of age, most of the layers of the adrenals are fully formed. Now, coming to anatomy, the largest part, we just discussed that some of the tissue may go extra-adrenally sites. The largest of the extra-adrenal neuroendocrine tissues is located at the aortic bifurcation. It's here, we can see in this diagram, or at the inferior mesenteric artery origin, like here, right here, these three small yellow dots. And this is designated as the organ of Zucker-Candle. This organ of Zucker-Candle will come frequently because this is one of the most common sources of extra-adrenal pheochromocytomas. Now, adrenal medullary tissue also may be found in neck, urinary bladder, and para-aortic regions, but most of the times it is found below the diaphragm. Now, coming to the physiology part, adrenal cortex contains 3 layers. So the cortex is the outer part. Here we can see in the diagram, there's a capsule, then there's a cortex, and then in the middle is the medulla. So cortex has 3 layers, and they produce mineralocorticoids, glucocorticoids, and sex hormones, which are out of this talk today. But here we come to the adrenal medulla, which is the most important part. It forms around 10 to 20% of the gland's volume. It's reddish brown in the color, and it produces the catecholamines, which are epinephrine and norepinephrine. Now, these cells that are present in the medulla here, they are arranged in the cords and polyhedral in shape. They're often referred to as chromaffin cells because they stain specifically with the chromium salts. Now, there are these enzymes, phenylethanolamine and methyltransferase. This particular enzyme converts norepinephrine to epinephrine, and this is only present in the adrenal medulla and the organ of Zucker-Candle. So that is where the epinephrine part is produced from. Now, after production, these catecholamines are stored in electron-dense granules, and while in circulation, they are bound to albumin. And the secretion, the hormonal secretion of epinephrine and norepinephrine, it is stimulated by various stress stimuli. And once they're released, these catecholamines are cleared by various methods, which are reuptake by sympathetic nerve endings or peripheral inactivation by another enzyme, which is catechol O-methyltransferase and monoamine oxidase. And generally, they are excreted by the kidneys. Now, metabolism also takes place in liver and kidneys by formation of metabolites, which are metanephrines and normetanephrines. Why these are important? Because the diagnosis of pheochromocytomas is based on the detection of these particular metabolites. And these metabolites may further undergo glucuronidation or sulfation before excretion from the body. Now, coming to diseases of the adrenal gland. So they may be divided to adrenal cortex and adrenal medulla. Now, out of the adrenal medulla disease, pheochromocytoma is the most important disease. And in adrenal cortex, the most important is incidentaloma. So incidentaloma is a disease of adrenal cortex, which by name suggests that it is an incidental finding whenever people go for some other workup of abdominal swellings and they find certain growths in the adrenal cortex. Now, Pheochromocytoma. If you break it down, pheo means dark, chromo means color, cyto is a cell, and oma refers to a tumor. So we can break it down to a dark colored cell tumor. So looking here, these are the normal adrenal cells and they become dark brown whenever they become tumorous or they begin to grow uncontrollably. So pheochromocytoma is a tumor arising from chromaffin cells from the adrenal medulla. And like we just said, they can also arise from the extraadrenal chromaffin tissue wherever it is present. Most importantly and most commonly seen is organ of Zucker-Kendall. And these are catecholamine secreting tumors. Pheochromocytomas have a history which dates back to quite a lot of time. And they were first identified in 1885 by Frankel. But they were not named as such until 1912 because it was Pick who noted the characteristic chromaffin reaction of the tumor cells, the color reaction. And the first successful adrenalectomies for pheochromocytoma were performed in Switzerland and United States by Roux and Charles Mayo respectively. Now, just to have a look, these are the healthy adrenal glands. And whenever they begin to produce too much of adrenaline or norepinephrine, the color changes. That is why they become dark in color and hence named so pheochromocytoma. Now, coming to epidemiology, to understand the burden of the disease, the annual incidence of the disease is approximately 0.8 per 1 lakh person years. Now, prevalence in patients with hypertension, because hypertension is one of the most common signs that is seen in these patients. In patients with hypertension, the prevalence is around 0.1 to 0.6%. An overall prevalence of 0.05% in autopsy series, which means that many of the times, these are not diagnosed when the person is alive, but because of the complications which leads to death, they are discovered upon autopsies. In total, 4% of incidentalomas are pheochromocytomas. They may occur at any age, but the peak time is 4th to 5th decades of life, and there is no gender predilection. Now, most catecholamine secreting tumors are sporadic in nature. That is, incidental finding is a possibility, but approximately 40% are part of the familial disorder, the younger age group, especially because whenever, like I just said, that it's 4th to 5th decade, which is most common, that is for the sporadic groups. Whenever we find them in the younger population, even in kids also sometimes, so we must always look for the familial or the hereditary disposition in these particular patients. And these tumors, whenever they are in a familial setup or a hereditary setup, these tumors are most likely to be bilateral in nature, and either they are bilateral adrenal pheochromocytomas or paraganglionomas, which are extraadrenal in nature. So risk factors for the familial pheochromocytomas are certain familial disorders, which all of them are autosomal dominant inherited in nature. Most common of which are, they occur in families with MEN2A and MEN2B syndrome. Approximately 50% of these patients, MEN2A and MEN2B, may present with pheochromocytoma. Then VHL disease. Now 10 to 20% of patients of VHL disease may present with pheochromocytoma, also included within the tumor spectrum of neurofibromatosis type 1, NF gene 1, though the incidence is low, 2 to 3%, and many other such diseases. Now, another important finding is that familial paraganglionoma and pheochromocytoma syndrome is caused by mutations in the succinylcholine dehydrogenase family of genes. This is a particular subset of genes. And whenever pheochromocytomas are found in these particular subset, they are more likely to be malignant. All the familial ones are more likely to be malignant. Now, coming to the very, very famous 10% rule of the pheochromocytomas, is that they are mostly 10% bilateral, 10% may be malignant, 10% of them may be occurring in pediatric patients, 10% of them may be at extraadrenal sites like the aortic bifurcation and other areas of the body, 10% are familial, Though in the previous slide, if we go back and see, I just said that approximately 40% are familial these days. As imaging modalities have gone up and genetic screening has increased recently because of the advances in scientific nature, so this 10% familial has even risen up to around 40% familial, but though we still put it in the category of 10%. 10% are not associated with hypertension, which is a very common finding, and 10% may be calcified. That is, they may be almost redundant. So coming to clinical presentation, how do we find out that somebody has a pheochromocytoma? So this is usually suggested by the history in a symptomatic patient. Once we take history from a person, so we may elicit it by history. Otherwise, it may be discovery of a lipid-poor incident adrenal mass, which is an incidentaloma, on screening of abdomen by CT or MRI for some other complaint, maybe sometimes. Or the family history in a patient. Sometimes if parents have a family history and child has certain symptom like a headache, so we may just think of a pheochromocytoma in the child as well. Now, the average age of diagnosis is 47 years and average tumor size when detected is around 4.9 centimeters. And symptoms are present in approximately 50% of patients with pheochromocytoma. And whenever they present, they are typically paroxysmal in nature. Now, clinical features, the classic triad for presentation or diagnosis is headache, palpitations, and diaphoresis or tachycardia. And these are episodic in nature, most importantly. And remember, important to notice that most patients do not have all the three classic symptoms. So one may just present with a headache, one may have only hypertension, or sorry, palpitations, one may just complain of a diaphoresic or tachycardia. Now, generalized sweating occurs in up to 60 to 70% of symptomatic patients. And the symptoms, they can be incited by a range of stimuli like maybe exercise, micturition, defecation, any kind of other stimuli of stress also. And interesting finding is that smaller tumors are more likely to be symptomatic in nature. Then rarely the clinical features can be a little different from the normal ones. So patients may present straight away with a pheochromocytoma crisis, or also called as pheochromocytoma multisystem crisis. These patients may have either hyper or hypotension as well. They may present with hyperthermia, temperatures more than 40 degrees Celsius. They may be having mental status changes like severe anxiety and other organ dysfunctions like especially renal dysfunction because of the raised blood pressure. Symptoms of pheochromocytoma, whether they are mild, moderate, or severe, they're always caused due to tumoral hypersecretion of one or the combination of following catecholamines, which can be norepinephrine, epinephrine, and even dopamine. Some of the tumors can even secrete dopamine exclusively, so they may be even more difficult to diagnose at times. And of increased central sympathetic activity also contributes to the increase in such symptoms. Now, this is just a slide to show this mnemonic that the first three letters, PHE, pheochromocytoma, PHE. So P for palpitation, H for headache, and E for episodic sweating. So these letters itself show the triad that the pheochromocytoma present with generally. And 5H, hypertension, headache, hyperhidrosis or sweating, hypermetabolism, and hyperglycemia that they may present with. Now, this is a photographic representation where these are the two adrenal glands. One of them goes bad and the medulla part starts to release catecholamines, which are epinephrine or norepinephrine. And the person is almost in a state of flight or flight response. So which means increased blood sugar, increased blood flow to the muscles, dilated pupils, increased blood pressure, and increased cardiac output or tachycardia. Now, there are studies which show that nausea and vomiting sometimes may be a very disturbing feature in these patients of pheochromocytoma. And why does that happen is that pheochromocytoma, the circulating catecholamines increase in the body. And these circulating catecholamines, this we can see is the hindbrain here. So they go and act at the area postrema, nucleus tractus solitarius, and they all send signals to the central pattern generator, CPG, central pattern generator. The central pattern generator is a very specialized bundle of neurons, which causes all these responses in series. That is, elevation of the soft palate and closes the glottis, relaxation of the gastric fundus, contraction of the diaphragm and abdominal muscles, and intestinal retrograde contraction. So that leads to retching, nausea, and ultimately even vomiting can occur. So that is again because of the increased circulating catecholamines. Now coming to clinical signs, apart from after the history, the most common clinical sign here is hypertension, which may be sustained or paroxysmal in nature. Now, pheochromocytomas are one of the few curable causes of hypertension, and these are found in 0.1 to 0.2% of the hypertensive patients. Now, like I said, hypertension may be paroxysmal with intervening normotension. It may even be sustained with paroxysms or sustained hypertension alone. The presentation can be wide varied. So anybody with hypertension must be at least look for pheochromocytoma. Now, 5 to 15% patients present with normal blood pressure. That is why they go into the rule of 10, where they say that approximately 10% will not have hypertension. And as an abdominal mass, if we palpate, so it's very difficult to palpate the mass, but even if it is palpated, it is a non-mobile, smooth, and it does not move with respiration, never crosses the midline because these are small in size. Coming to the less common symptoms and signs that patients may present with are orthostatic hypotension, which reflects a low plasma volume because of the persistent vasoconstricted state. Cardiomyopathy, they may present straight away with cardiomyopathy, which is attributed to, again, the catecholamine excess, especially patients who have high amount of epinephrine as well. And this cardiomyopathy is similar to the stress-induced Takotsubo cardiomyopathy, which is also called as the broken heart syndrome. Now, these patients may also present with a pulmonary edema, and they may deteriorate with initiation of beta adrenergic blockade, because then the alpha adrenergic component becomes way more pronounced, and severe vasoconstriction and deterioration of pulmonary edema occurs. They also may present with insulin resistance, impaired fasting glucose, and apparent type 2 diabetes mellitus, which is directly related to the increase in catecholamine production and the stress hormones. Now, two rare presentations of pheochromocytoma can be patients that secrete with a tumor that secrete only epinephrine. Sometimes the presentation can be like that. So such patients will present with episodic hypotension instead of hypertension, or rapid cyclic fluctuations of hyper and hypo. As fast as every 7 to 15 minutes, the blood pressure may change, can occur via an uncertain mechanism. But these are rare presentations. Now, patients can be totally asymptomatic as well, like I said, incidental finding. So with widespread use of imaging, now CT and MRI have become so common for so many conditions that 60% of the patients are discovered incidentally. Pheochromocytoma in pregnancy, I would just like to speak a slide about it, because pregnancy is a very dear and precious state for everybody. So pheochromocytoma is a rare cause of hypertension during pregnancy though. But what patients present with here is that the supine position during pregnancy, where aortocaval compression generally causes hypotension. But here what happens is when the woman lies down, the gravid uterus compresses the tumor. And what happens is instead of hypotension, there is a paradoxical supine hypertension in such patients, which becomes normal in the sitting posture or the erect posture. And it may be difficult to distinguish from preeclampsia, especially if the woman also presents with proteinuria. Then it may be difficult to differentiate it from PIH. Now, MRI without gadolinium is the imaging test of choice in these pregnant women, because it can be life-threatening. And here, spontaneous labor and delivery should be avoided. Cesarean is the preferred mode because there is less risk of maternal death than vaginal delivery here. Now, coming to the malignant potential of these pheochromocytomas, like I said, approximately 10%, as per the 10% rule, approximately 10% are metastatic in nature, the range being 8.3 to 13%, especially the familial ones. And in the familial ones, this 10% can be even higher, reaching up to 30 to 40% because of the more common use of genetic mapping of these families to find them early, to catch them early. Now, histologically and biochemically, the malignant and the benign ones are the same. So it may be difficult to say which are the malignant ones. So how do we know? Only reliable clue to the presence of a malignant pheochromocytoma is local invasion of the tumor into the surrounding tissues. And this local invasion may even occur after resection of a pheochromocytoma, even up to 30 years later. A few case reports have been reported where patients had resection in the childhood, and in the adulthood, they reported back with a malignant pheochromocytoma. Also, patients with succinate dehydrogenase subunit B mutations are more likely to develop metastatic disease. According to 2017 World Health Organizations, all pheochromocytomas have some metastatic potential. So that basically again impresses the importance of a regular follow-up even after resection of the tumor. Now, differential diagnosis. A few conditions can masquerade as pheochromocytoma, which may be hyperthyroidism, which is uncontrolled, certain cardiac conditions like cardiomyopathies, carcinoid tumors which are functioning, which release serotonin, and anxiety or panic attacks. They may also present just like pheochromocytoma with sweating and palpitation, tachycardia, etc. So investigations, diagnosis typically is made by measurements of urinary and plasma fractionated metanephrines and catecholamines. Now, as per the modality is divided into two parts. If there is a low index of suspicion. Now, who are these patients with low index of suspicion? They are patients with resistant hypertension or hyperadrenergic spells. If some of them present like that, then we must first go for a 24-hour urinary fractionated catecholamines and metanephrines. So urinary sample is preferred here, which is collected over 24 hours. And if there is a high index of suspicion, example, patients with family history of pheochromocytoma, if they are a part of a genetic syndrome that we discussed, or there's a past history of a resected pheo, and now again we see an adrenal mass coming back, or incidentally discovered adrenal mass is there, then we must go for plasma fractionated metanephrines. That is the first line here. And also in children, we must go for the plasma metanephrine levels, not for urine, because 24-hour urine collection may not be done meticulously in the children, as it is very difficult to collect 24-hour urine samples there. So urinary metanephrines are highly sensitive and specific for the diagnosis. Coming to radiological studies, nowadays CT scans and MRI scans are being used liberally, and also rightly so, because they are highly sensitive and even specific for pheochromocytomas. MRI scans are 95% sensitive and almost 100% specific for pheochromocytomas, because they have a characteristic appearance on T2 weighted images after gadolinium. But this particular gadolinium should be avoided in pregnant patients. And also the imaging, whenever it's done, CT or MRI, it should include all the region from diaphragm and below, because the extra-adrenal pheochromocytomas or the paragangliomas, they may occur anywhere below the diaphragm. Thank you so much for the patient hearing. That was all from me. And this is our OPD building at PGMS Trauma Center.
Thank you, Preeti.
Thank you, ma'am.
For nicely highlighting the anatomy, physiology, and pathophysiology part, along with clinical presentation of such an important disease. So questions we are going to take up at the end of the 3 talks, no?
Yes,
Dr. Satish? Okay. So now I invite Dr. Sushila to introduce the other speakers. Dr. Sushila, please.
Hello, good evening, everyone. Our next speaker, she is a graduate and postgraduate of our institute, and we are lucky to have her as a faculty with us now. She has a number of publications to her credit. She is a reviewer for many national and international journals, and no wonder that's why she has been selected on the editorial board of the Northern Journal of Indian Society of Anesthesiologists as an assistant editor. So let us welcome our the next speaker, Dr. Tina Bansal. And Dr. Tina is going to speak on perioperative risk assessment and preoperative preparation of patients who are to undergo pheochromocytoma surgery. Over to you, Dr. Tina.
Thank you so much, ma'am. First of all, I extend my heartfelt thanks to Radhakrishnan sir, Jayashri Sood ma'am, Savita Saini ma'am, and Sushila ma'am for considering me as speaker for this webinar, and I also extend my greetings to my co-presenters, Dr. Preeti and Dr. Priyanka. I should be speaking on the topic. Pheochromocytoma, perioperative risk assessment and preoperative preparation. Pre-anesthetic assessment. First of all, verification of history is done. Then assessment of severity of hypertension is done. Hypertension in these patients can be baseline normal blood pressure with paroxysms, baseline elevated blood pressure with intermittent paroxysms, or persistently increased blood pressure. Then assessment of end organ damage is done. Cardiac evaluation is done by chest X-ray, ECG, and echocardiography, and renal function evaluation is done by urea, creatinine, and electrolytes. Other investigations which are done in these patients are complete hemogram, serial hematocrit, blood sugar, and calcium. The majority of patients present with hypertension, which can be sustained or paroxysmal. It is equally important to know that a subset of patients can present with normal blood pressure, which is usually seen with low circulating catecholamines. Normotensive pheochromocytomas have comparable perioperative hemodynamic instability to those with clinically significant preoperative hypertension. Therefore, it is prudent to optimally evaluate and prepare every patient with pheochromocytoma before surgery. Pheochromocytoma presents significant challenge to anesthesiologists. Surgery in poorly prepared patients can result in serious morbidity and mortality. Adequate preoperative evaluation and preparation is crucial before surgery for these patients. Now coming to the importance of preoperative preparation. The importance of preoperative preparation is to reduce the possibility of a catecholamine surge and its effect on target organs upon induction of anesthesia, tumor manipulation, in addition to ensure stability in post-operative care. Preoperative evaluation includes evaluation for cardiovascular system complications from high circulating levels of catecholamines and initiating antihypertensive medications to improve cardiac dysfunction and achieve adequate blood pressure control to avoid intraoperative hemodynamic instability. Now coming to the objectives of preoperative preparation. The objectives are control of blood pressure, reversal of chronic circulating volume depletion, control of heart rate and arrhythmias, assessment and optimization of myocardial function, and reversal of glucose and electrolyte disturbances. Close communication and coordination between anesthesiologist, surgeon, endocrinologist, and cardiologist is key to successful management. Now coming to our first objective, which is control of blood pressure. Standard practice is preoperative alpha blockade, which aims to provide preoperative blood pressure control with subsequent restoration of blood volume, which may be titrated using serial hematocrit. Why alpha blockade first? Treatment with beta adrenergic blocker should never be initiated as a sole agent or before adequate alpha blockade. Doing so might precipitate a catastrophic hypertensive crisis because unopposed alpha receptor stimulation can result in significant increase in blood pressure. Alpha adrenergic blockade is administered starting 10 to 14 days pre-operatively, although a longer course of treatment may be required for patients with cardiomyopathy or refractory hypertension. Medications for blood pressure control are alpha blockers and calcium channel blockers. Alpha blockers are used in hypertensive patients and calcium channel blockers are used in normotensive patients. Now coming to alpha blockers, these are first-line agents for pre-operative blood pressure control. These are of two types, non-selective and selective. In non-selective, there is phenoxybenzamine, and selective are prazosin, tirazosin, and doxazosine. Phenoxybenzamine. It is non-competitive, that is, it blocks both alpha-1 and alpha-2. It is long-acting. Non-competitive nature allows it to maintain its alpha blockade during a catecholamine surge. Long half-life of the drug makes it easy for patients to be compliant. However, it should be stopped 24 to 48 hours before surgery due to its long half-life. Dose is 10 mg twice daily, which is increased by 10 mg per day until there is normalization of blood pressure and orthostatic hypotension. This requires daily blood pressure monitoring in the supine and standing position. As phenoxybenzamine is non-selective alpha blocker, so alpha-2 receptor blockade results in reflex tachycardia. The degree of reflex tachycardia determines the need to initiate a pre-operative beta blockade. However, beta blockers should be started once the alpha blockade has been achieved. Advantages of using phenoxybenzamine are adequate dosing reduces vasoconstriction, reduces intraoperative hypertensive crisis, and contributes to improved surgical outcomes. Side effects of phenoxybenzamine are nasal stuffiness, syncope, dizziness, headache, post-operative somnolence, postural hypotension, and perioperative hypotension unlikely to respond to pressor agents. Specific alpha blockers are, these are specific alpha-1 blockers. These are short-acting. In this we have prazosin, doxazosine, and tirazosin. Prazosin is used in dose of 2 to 5 mg 2 to 3 times a day. Doxazosine is used 2 to 8 mg daily with maximum dose of 32 mg per day, and tirazosin is used 2 to 5 mg daily. Specific blockers as compared to phenoxybenzamine. The advantages of specific alpha-1 blockers are shorter duration of action, decreased likelihood of post-operative hypotension, and avoidance of reflex tachycardia, hence no need for pre-operative beta blocker. Its disadvantage is that they have shorter half-life, hence these drugs require more frequent dosing to sustain alpha blockade. Now coming to calcium channel blockers, these are specially useful for normotensive patients. These can be used as monotherapy in normotensive patients or in combination with alpha blockers when blood pressure is not well controlled. Calcium channel blockers which we use are amlodipine and nicardipine. Calcium channel blockers versus alpha blockers. The advantages of calcium channel blockers over alpha blockers are that there is no orthostatic hypotension. Calcium channel blockers lessen the severity of catecholamine-induced vasospasm, therefore are particularly useful in subset of patients with catecholamine-induced myocarditis. Perioperative hypotension may still respond to pressor agents as opposed to those patients who are completely alpha blocked. Now coming to our second objective, that is reversal of chronic circulating volume depletion. The catecholamines cause intense vasoconstriction through alpha-1 receptors. Alpha blockers help in expanding the highly contracted intravascular volume. Serial hematocrits give a guide to the effectiveness of volume expansion. Usually, a 5 to 10% fall in hematocrit is seen in well-prepared patients. Now coming to our third objective, that is control of heart rate and arrhythmias. Tachyarrhythmias may result from epinephrine secreting tumors or secondary to alpha blockade. Selective beta-1 blocker, atenolol or metoprolol are preferred and must be started after complete alpha blockade has been achieved. Beta blockers may be dangerous in patients with catecholamine-related cardiomyopathy and hence can lead to hypotension, bradycardia, or even arrest. Doses are titrated to a goal heart rate of 60 to 80. Now coming to our next objective, which is assessment and optimization of myocardial function. For this, thorough cardiovascular evaluation is needed. The primary mechanism for these abnormalities is related to the catecholamine-induced coronary artery vasoconstriction that restricts myocardial blood flow. ECG may reveal ventricular hypertrophy, tachyarrhythmias, myocardial ischemia, and non-specific STT changes. Patients with chronic hypertension may have hypertrophic cardiomyopathy, which can be chronic, hypertrophic or dilated, or acute. Hypertrophic cardiomyopathy leads to diastolic dysfunction, and dilated cardiomyopathy leads to systolic dysfunction. Patients with Takotsubo cardiomyopathy present with left ventricular basal or apical hypokinesis despite normal coronary arteries. Hence, echocardiography is recommended to evaluate for presence and degree of cardiomyopathy. Echocardiography may also be useful for determining the improvement after antihypertensive therapy has been initiated. Now, our next objective is a reversal of glucose and electrolyte disturbances. Hyperglycemia can occur due to increased glycogenolysis, impaired insulin release, and peripheral insulin resistance. Hyperglycemia needs to be treated preoperatively. Electrolyte measurements will identify catecholamine-induced renal impairment and should be treated preoperatively. Now we have optimized our patient, but is still anything needed? Yes. Now there is need for assessment of our optimization, which we have done. And this assessment is done by evaluation of alpha adrenergic blockade. This is done by Roisen's criteria. Blood pressure should be equal to or less than 160/90 or less in the last 48 hours prior to surgery. Mild orthostatic hypotension indicates optimal alpha blockade, but blood pressure should not be less than 80/45. No arrhythmias should be there. ECG should be free of STT changes for more than 1 week prior to surgery, and ventricular ectopic less than 1 over 5 minutes. Intraoperatively, additional alpha adrenergic and beta adrenergic blockade may still be necessary because their effects can be overcome by a large number of catecholamines during surgical manipulation. Now coming to pre-medication for these patients, sedation and angiolysis prevent marked hemodynamic changes pre-operatively. Benzodiazepines are preferred as these help to decrease catecholamines release. Phenoxybenzamine should be withdrawn 48 hours prior to surgery, which is most frequently prescribed for preoperative use. Selective alpha blocker to be given at night prior to surgery, and beta blocker to be given as per schedule. Special scenario and consideration: Pheochromocytoma patient for non-pheo surgery. Elective surgery to be postponed, and elective resection of pheochromocytoma should be planned first if a patient with pheochromocytoma presents for elective surgery. And if this patient is for emergency surgery, then patients for emergency surgery should be tried to optimize as far as possible before surgery. Now to conclude, pheochromocytoma presents significant challenge to the anesthesiologist. Successful management requires meticulous preoperative assessment, optimization, and further assessment of optimization. Thank you.
Thank you, Dr. Tina, for such an excellent presentation and
Thank you,
description of
ma'am.
how to prepare our patient. And I'm reminded of incidents when I was a postgraduate student and we were not running a pre-anesthetic clinic in the OPT. I went to see, I was reading Pheochromocytoma as a postgraduate student. And I just finished reading Pheochromocytoma and I went to the surgery ward for my pre-op round. So when I saw a patient, there was a patient who had an abdominal mass for exploratory laparotomy. Although the CT scan was, there, but it was not so much in use in our country that time. And they had just put this patient for an exploratory laparotomy that she has a mass abdomen which needs to be seen. So when I was seeing this patient, she had hypertension. When I took a history, she says that, I asked her that, are you on treatment for hypertension or something? She says, no, I'm not on any treatment. So what is your problem? What do you feel? I said, she says, I get headache. You are telling me I have hypertension and I get so much restless and there is so much palpitation that that I'm so troubled that what has happened to me, and I'm drenched in the sweat. So I said, oh my God, this is pheochromocytoma. So the surgery registrar that time, I told him, sir, this patient cannot be taken up tomorrow because we need to work up and prepare this patient. To me, she seems to be pheochromocytoma. He just laughed at me, he thought, this young girl has just read pheochromocytoma and just thinking any abdominal tumor will be pheochromocytoma. And actually that patient, when investigated, she came out to be pheochromocytoma. She was prepared and operated and she had a successful surgery. So now we go next to Dr. Priyanka Bansal. Dr. Priyanka Bansal, she is an assistant professor with us and she has a keen interest on, can we have Priyanka there? Yeah. So she has a keen interest on, a number of areas and she's very good at doing her job. So she is going to talk to us about anesthetic management, intraoperative, how we take care of the patient. So Dr. Priyanka Bansal.
Ma'am, I would like to extend my gratitude to you and Dr. Radhakrishnan. It's an honor indeed, ma'am. Thank you for letting me present on this platform. It's not
For where we are sure.
Anesthetic management of pheochromocytoma. There is basically two times when we are guarded like catecholamine surgeries and or during its deficiency. Initially, we will have an upsurge of catecholamine, maybe because of laryngoscopy or peritoneal insufflation, surgical stimulation, or during tumor handling, and sudden deficiency following tumor ligations. It is very important to emphasize the importance of careful planning, meticulous technique, and close communication with the surgeon. On a lighter note, it should not look something like this on the anesthesia side. Neither should it look like this on the surgical side. Now, to begin with, relief of anxiety is important because apprehension as it is associated with catecholamine surges. For this, the longer-acting benzodiazepine, lorazepam, diazepam a night before surgery are preferred, or we can give IV midazolam prior to the patient enters the OT room. The best thing is a calm patient who is less prone to hypertensive crisis at induction. Invasive monitoring, like invasive arterial monitoring, has an important role. I'll be discussing this slide a little more in detail later on. And central venous cannulation is required for fluid management. Pulmonary artery catheters as well as intraoperative TEE probes in appropriate patients are required as well. Now, number of drugs, we have to be prepared with these drugs preoperatively, like antiemetics, H2 blockers. Antiemetics, metoclopramide, we have to avoid. It can provoke a hypertensive crisis. Short-acting alpha-1 antagonists are started on the morning of the procedure. Longer-acting ones like phenoxybenjamin, doxazocin, if they are started, they have to be withheld 12 to 24 hours before surgery. The vasodilated drugs like NTG, SNP, nicardipine, we have to be prepared with the infusions as it is. The time may be less later on. And esmolol infusion, beta blockers are given for heart rate control. Esmolol is particularly important because of its immediate action. And vasoconstrictors, which may be required, like norepinephrine and vasopressin. Catecholamine cardiomyopathy in its special role, like inotropes, epinephrine, dobutamine, and milrinone, which has a particular important function in right ventricular dysfunction. For rapid volume expansion, we will prefer colloids, plasma expanders, and blood products. Now, anesthetic induction is the most critical part. Commonly used are the propofol and etomidate, but etomidate has a higher, has an upper hand because of its cardiovascular stability, especially in volume depleted patients. Ketamine is to be avoided due to its sympathomimetic effects, as are ephedrine and meperidine. Airway instrumentation is attempted after adequate anesthetic depth to avoid tachycardia and hypertension. And agents causing histamine release are to be avoided, especially like morphine, hydromorphine associated with histamine release. Remifentanil is successful, but we, as in our institute, we are using fentanyl. Dexmedetomidine, it is a centrally acting selective alpha-2 receptor agonist with sedative and analgesic properties. It has a slower onset. The most important part which we have to discuss for dexmedetomidine is, in addition to its sedative analgesic properties, its central sympatholytic effect results in a substantial reductions in the plasma norepinephrine levels, making it a potentially very attractive agent for pheochromocytoma surgery. Now, discussing little short like choline, it leads to stimulation of the autonomic ganglia, which facilitate muscle fasciculations. They compress the tumor and the result is the sudden catecholamine surge. Neuromuscular blocker, pancuronium, it has a vagolytic effect. It triggers the pressor response, avoided. Vacheron is most commonly used. It has no autonomic effects, no histamine release, and the most preferred one. As far as the intravenous agents are concerned, now commonly fentanyl, IV, lidocaine, obviously they are preferred. Esmolol is preferred, and infusions, NTG, SNP, we have to prepare with these infusions. Regarding the inhalational agents, enflurane, isoflurane, sevoflurane, they all are preferred, but sevoflurane, it's relatively stable hemodynamic profile, less sensitive to the airways, it is preferred. Halothane sensitizes the myocardium to catecholamines, a well-known fact. It is arrhythmogenic, hence avoided. Desflurane similarly follows. Now, discussing the monitoring in detail, aside from the standard ASA monitors, intra-arterial monitoring is a must. It helps us to know the beat-to-beat variations. Central venous catheterization is required. It is a standard of care. It helps to monitor the right atrial pressure besides delivery of vasoactive agents. Schwann-Ganz catheter is more important for left ventricular function, especially in significant myocardial disease and pulmonary hypertension. It also helps us to monitor the cardiac output, pulmonary capillary wedge pressure. Pulmonary artery catheter has more important role post-operatively after fluid resection for guiding the fluid management in ICUs, particularly in unstable patients. Now for TE, real-time monitoring of the intravascular volume status, especially the volume status of the left ventricle, it is very important because large amount of fluid may be going. Then earlier detection of myocardial wall motion abnormality, especially in diagnosis of intraoperative MI. As far as the pain management is concerned, obviously a very important topic for us. Spinal anesthesia and epidural analgesia occasionally have been used with satisfactory results. Use of combined regional technique with GA must be balanced against the risk of hypertension during its placement, because sympathetic blockade does nothing to protect against the catecholamine release during tumor manipulation. Here comes a role like anti-anxiety drugs, which we were using before. Local anesthesia block like tab block may be considered after intubation. Erectospiny block, it is a more recent one. It may be considered with the added advantage of catheter placement for post-operative management. Basically, it is a multimodal analgesia. Now for intraoperative hypertension, it may be transient, it may be longer acting. Transient is usually because during positioning, like before I mentioned during intubation, it is usually because of excessive catecholamine release from the nerve endings. Tumor manipulation also results in hypertensive crisis. It is at a significant increase in the plasma levels of norepinephrine, and it leads to severe hemodynamic instability, including significant reductions in the cardiac output and associated left ventricular systolic and diastolic dysfunction, along with the wall motion abnormalities. It lasts longer. It is an urgent situation. Now for acute hemodynamic crisis, usually because it results in increase in the epinephrine and norepinephrine. Patient presents with severe bradycardia, tachycardia, tachyarrhythmias, and the answer is deepening the plane of anesthesia. We have to use direct arterial vasodilators like SNP, NTG to reduce the preload. Rapid onset, they both are rapid onset, they're easily titrable. Nicardipine, phenoldopam are also used, particularly they're peripheral vasodilators. Beta blockers also required esmolol, etc. for heart rate control. Magnesium sulfate has a especially important role in severe resistant hypertension in Pheochromocytoma, and also useful in ventricular arrhythmias, especially in Takotsubo cardiomyopathy, as already my seniors have mentioned before. It is a vasodilator and it's a strong calcium antagonist. It directly blocks the receptor. Not to emphasize again, the communication with the surgeon, both anesthetist and surgeon, is important before tumor manipulation. Episodes are so sudden dip, sudden increase, and that's why I've mentioned the importance of infusions preoperatively. Hyperglycemia is common. Insulin infusion therapy should be a routine. Now, what happens is sudden intraoperative hypotension. We have to maintain a cool also in this. Sudden hypertension may be because of a contracted plasma volume. It may be because of surgical bleeding, or it may be anesthesia-induced vasodilatation. Management is large volume fluid infusion. Discontinue the vasodilators. Intraoperative TEE has the role. I have already assessed this function before. For the vasoactive agents, dopamine and norepinephrine are the most commonly used. For refractory hypotension, vasopressin and IV methylene blue have found a particular important role. Vasopressin does not rely on the peripheral receptors for its pressor effect. IV methylene blue has a vasoplegic syndrome. Especially it is useful in vasoplegic syndrome associated with hepatic or renal failure. It's a CGMP blocker. Steroid replacement is especially important in bilateral adrenectomies. Now, for the immediate post-operative management, if there is persistent hemodynamic instability, post-operative ventilation has to be considered. If the patient is drowsy, patient is unresponsive, then rule out any electrolyte abnormalities, hyponatremia or hypoglycemia also. If there persistent hypotension in spite of all the measure, then surgical bleeding may be the reason, inadequate fluid resuscitation, residual anesthesia-induced vasodilatation. If there is persistent hypertension postoperatively, the reason may be fluid overload, return of autonomic reflexes, inadvertent renal arterial ligation, residual tumor, or recurrence. An important topic already has been discussed in detail by Dr. Preeti. Just to emphasize more on that, it is rare, right? Pheochromocytoma in pregnancy may be rare, 1 out of 54,000 pregnancies, but when undiagnosed, it as well as maternal, approximately 50%. Obviously, we can't ignore it. And why it is missed? Because there is also prevalence of gestational hypertension as well as preeclampsia. Now, as far as the lab diagnosis in pheochromocytoma in pregnancy is concerned, it is the same as in non-pregnant patients, fractionated metanephrines in blood and urine. Alpha blockers we are using preoperatively, but the important point is we have to take care of the uteroplacenta circulation as well. Now, as far as the surgery is concerned, laparoscopic adrenalectomy is the answer. Either we have to use it before 24 weeks of gestation or after delivery. Now, there is in late trimester also we can prefer it, but PCC resection has to go simultaneously with the cesarean section. Now, the last, patients with pheochromocytoma have a significant risk for major adverse cardiac complications in the perioperative period. Successful management requires careful preoperative optimization, meticulous planning, and hemodynamic management. All patients need to be monitored vigilantly in the postoperative period because of the higher chances of complications. Thank you with a sweet message. Thank you, Anand.
Thank you, Dr. Priyanka, for your excellent presentation on how to manage these patients intraoperatively and what care to be taken in the post-operative period. And I would like to have Madam Savita Saini's comments, if Madam is there.
Yeah, actually, this is one of the condition or disease where it really requires extra meticulousness in managing the patient throughout perioperative period, as highlighted by all the speakers. And this is really important, and all the speakers have really highlighted very well, right from the clinical presentation, its intraoperative management and anesthesia and postoperative management. Dr. Sushila can take up the questions from the audience if they have. Dr. Sushila? Yeah, Dr. Sanish will have.
Yeah, if there, we are right in time for the question answers. So if there are any questions, I'm sure our speakers would like to answer. So these patients, still we have some questions. These patients, they have to be followed up after the surgery as well. So they have to go for a biochemical evaluation yearly so that we can diagnose that if there is any recurrence or any metastasis occurring or if there is a residual tumor. And yearly they even have to go for an imaging study to diagnose any tumor that is coming up. So, and yes, preoperatively, like mentioned, we have to prepare our patients very well, and with good preparation, everything goes beautiful. So I find no questions in the chat box. So over to Sanish.
Ma'am, we had a wonderful session, and if moderators would like to have bring out some points and clarifications, we can do that now. Otherwise, we'll ask Dr. Baljit Singh to do the vote of thanks. Any questions from the moderators?
No, there are no questions as such.
So we thank Dr. Preeti, Dr. Tina, and Dr. Priyanka for having, done a good presentation, and they were so good that they accepted on a short notice that one of our participants got COVID and could not participate. So the next one took over. Thank you to everybody, and over to Dr. Baljit Singh, sir.
Thank you, ma'am.
Thank you so much, Dr. Sheila.
Thank you, sir. Thank you so much.
First of all, I would like to thank you all for a wonderful session that you had on Pheochromocytoma. It may be a very, not a very rare, I would say, relatively uncommon condition, but when you come across it, you understand how difficult it is to deal with this problem. And all the three speakers, they have done a great job. And first of all, Dr. Preeti Gelot, she gave a very good overview, good slides and good presentation as well. And thereafter, it was followed by Dr. Tina Bansal with regard to perioperative risk assessment and preoperative preparation of the patient. And following that, it was Dr. Priyanka Bansal who did an excellent job with regard to the management of these patients. I think everything related to all the challenges which the anesthetists meet in the management of pheochromocytoma have been very, very well covered. And the presentation of all the three speakers was, I would say, very, very good. I'm so happy to have listened to and sat through all the whole of the program. Well, with regard to the floor managers, as Dr. Radhakrishnan put up, Dr. Savita Seni and Dr. Sushila Taksak, you did a great job of handling everything. And I thank you for that. On behalf of Indian College of Anesthesiologists, I pay my sincere thanks to you both, and of course to all the three speakers who done a wonderful job. I also would like to thank all the participants who joined in this webinar. I think it is basically the participants which keeps this program going on, because it's quite a motivating force. All the participants who actively take part in these webinars. And apart from that, those participants who are not shown here, they see the program through YouTube. And I think it's very satisfying that whatever effort is put in by the organizers of each webinar, it's so very well received by everyone. Well, thank you so much once again, everyone. And to all the participants, till we meet again on the next Wednesday. The program has already been shown on the screen by Dr. Sinish. This program is, this webinar will be on quality and safety in anesthesia practice. And, very good speakers again, like every webinar. We have Dr. Sangeeta Khanna from Vedanta Institute, Gurgaon, and Dr. Raj Tobin from Max Saket, and Dr. Anand Sharma again from Vedanta. All the three speakers are from Delhi, and would like to see all of you participating in the next webinar also. Thank you so much, and good night. Stay safe and stay happy. Good night.
Thank you,
Thank
sir.
you very much.
Thank you, Dr. Baljit.
Thank you. Good
And
night. Thanks
thanks
a
to
lot.
all the presenters. Very well.
Yes, yes. Thank you. Thanks a lot.